Good evening, everyone. I'm John Symanski, and I'm a musculoskeletal radiologist at the University of Wisconsin. And I'm welcoming you to the last Society of Skeletal Radiology Education Club webinars of this season. And for our last episode of the season, I am looking forward to showing you some very interesting spine cases. So disclosures, I have no financial disclosures. I do volunteer for the ABR, and my opinions do not reflect those of ABR. So our plan for today, we're not going to be showing you bread and butter spine cases. We're going to be showing you interesting and fun spine cases. So accordingly, some of these are black diamond or a double black diamond in difficulty. That being said, the point of this webinar is to have fun, show some interesting cases. So please dive in. I'll ask for your feedback and opinions on cases when you see a little blue box with instructions in the corner. So please do send what you think in our chat function. So without further ado, our first case is a 44-year-old woman. She's had waxing and waning pain for many years now, but now she has some right lower extremity symptoms, including weakness and pain, and even some incontinence. So these are the images. So please use your chat feature to let everyone know and let me know kind of what you're thinking for this first case. All right. We got some people talking about herniation and Schmorl's node. We'll just keep these images up for just a couple more minutes, see what people are thinking. We have a first differential of the evening, arachnoid. Assuming we're talking about a web or cyst. All right, so yes, there is a Schmorl's node here, but the most salient finding here is this is a case of ventral cord herniation. So that is a spinal cord herniating ventrally through the dura mater. And when I first learned about this, I was perplexed. They said that's ridiculous. There aren't these giant holes in the dura, and how would the spinal cord even make its way through there? But there are some theories. These almost always occur in the mid-thoracic spine, where you have some kyphosis, and that draws the spinal cord very close to the ventral dura. And if you have any sort of inflammatory event, like in this case, this isn't our case from today, but if you have like a disc herniation, that can create some inflammation into the dura. And there's some thoughts that this leads to some adhesion of the spinal cord to the dura, and that sort of rubbing and adhesion over time can actually whittle a hole in it, and this spinal cord can eventually nestle its way through actually a frank dural defect. So that cord kinking compromises the blood flow, the venous and the arterial blood flow in the spinal cord, and this can lead to a myelopathy. It leads to a hemicord syndrome, Brown-Séquard syndrome. We don't know why, but that's how these usually present. On imaging, we see focal kinking of the cord with the anterior displacement, and this causes enlargement of the dorsal subarachnoid space. The cord may appear thinned. This one doesn't, but they can appear very thinned where it's kinked. And the most important feature of this diagnosis, and what helps us differentiate it from the differential diagnosis, is you have a complete loss of that ventral CSF column. If the cord is herniated through the dura, there should not be CSF flowing anterior to the cord. So as someone mentioned in the chat, the differential here is some sort of extra arachnoid matter dorsally in the thecal sac. This can be either a web of arachnoid or even a rounded focus of arachnoid that would be even just a cyst. So just like anterior cord herniation, there's enlargement of the dorsal subarachnoid space, and the cord can appear thinned. With the web or cyst, the morphology of the spinal cord resembles a scalpel, and they kind of help you out. The scalpel has a rounded edge to the blade at the tip, and there's kind of this rounded edge where the spinal cord tapers. But most importantly, the CSF ventral column should be patent It theoretically may not be patent if the web or cyst is large enough, but if you have a ventral CSF column and you have a kinked spinal cord or mass effect on the cord without really seeing much, there's a good chance it's probably a dorsal thoracic web or cyst. Here is a cartoon from the neurosurgery literature describing the morphologic differences with the cord, with the anterior cord herniation, the sort of knuckled, kinked appearance, and with the dorsal arachnoid web or cyst, the scalpel appearance. So coincidentally, in preparing this talk, I made these slides for the cord herniation about a week or two ago. And then a few days ago, we had a new case hot off the press. What is this? On the transaxial image here, it looks like the CSF column anteriorly may be completely lost. But on the sagittal image, you can see that there's still some preservation of the anterior CSF column. So this is almost certainly going to be a web or cyst. Moreover, there's a scalpel-like morphology to the spinal cord. And then another interesting finding we have not talked about yet is there's a segment where we don't have a normal CSF flow void. This is a fairly T2-weighted image, which means there's a longer TE, and means the CSF has time to come in and out of plane, and it can cause some dephasing artifact like we see here. Here, there's no dephasing artifact. This is not a reliable sign for differentiating cyst or web because you can have propagations of the CSF fluid through thin webs, or it can even propagate through the cyst like a water balloon. But this is an ancillary secondary finding we can sometimes see when we have a cyst or a web impeding CSF flow in the dorsal thecal sac. So this is back to our patient. She was treated surgically, which confirmed the cord herniation. They resected that abnormal area of dura and gave her a patch of pericardium to repair the dura. So the next case is a 65-year-old woman. She has an unsteady gait and has some lower extremity numbness now for 6 months. And actually, she's now unable to work. So how does she first present to our medical system with imaging? Probably won't be a surprise to many of you. She presented with a chest CT, PE protocol in the ER for shortness of breath. She did not have a PE, but at this point, we did notice that she had what looked like a hemangioma in the T11 vertebrae. A typical corduroy appearance on sagittal images and the polka dot kind of celery stalk appearance on the sagittal images and the polka dot appearance on the transaxial images. But something about it looks a little bit different than our run-of-the-mill hemangioma. First of all, the spinal canal is very narrowed. And second of all, it looks like whatever is here is like extending into the paraspinal tissues in the posterior mediastinum. If we look at a harsher bone window, we can see that this process involves the whole vertebra, not just the vertebral body. And here we can see it involving the posterior elements, and it's narrowing the spinal canal compared to the normal adjacent level at T10. That's the image on the right. So here's the MRI. And please text to the webinar chat what you think this could be, a differential, funny quip. Okay, we have some people talking about an aggressive vertebral hemangioma, atypical hemangioma, aggressive hemangioma. All right, so you guys are pretty good. This is a difficult case. Maybe we need to do some triple black diamonds, but here's a case showing the transaxial images. Notice on the T2 image, there's no CSF. This is the dura mater just completely plastered around the spinal cord. The spinal canal is very narrowed at this level. You can see some compression of the cord on the sagittal images. So this indeed is an aggressive vertebral hemangioma, which is a rare form of hemangioma where the bone expands And actually, the hemangioma can grow outside the bone. You get extraosseous extension of the hemangioma. Like Paget's disease, when you have one of these, it tends to involve the entire vertebra. Most we see in the thoracic spine. And most of the symptoms, if they are present, are from mass effect. So compressive myelopathy or a radiculopathy. And like most compressive myelopathy cases, it's treated with surgical decompression. However, these tumors, as you can imagine, are quite vascular. Like other tumors that are quite vascular, like renal cell carcinoma metastasis, it is first treated with preoperative embolization prior to decompression. So in this case, our interventional colleagues subselectively catheterized the left and right intercostal arteries at T11. Well done. Especially that T11 one that was feeding the lesion quite nicely, and they did a gel foam embolization prior to the posterior decompression, and then they fused these two segments or these three segments. On the imaging after the procedure, we still have all that hemangioma in front of the vertebra, growing out of the vertebra in the vertebral body, but you can see the posterior elements are now missing, and we now have CSF around the spinal cord. So the compression has been relieved. That's great. All right. The next case is a 57-year-old woman. She has neck pain, and she has end-stage renal disease and has been on dialysis for quite some time. All right. We have someone voting for infection, maybe TB. Amyloid. Fracture. Speaking of fracture, why don't we give you a bone sensitive sequence? We'll throw in a CT as well. Pott's disease. I think that's another vote for tuberculous spondylodiscitis. All right. So the findings here are not pathognomonic for this entity, but certainly suggestive of this entity. And this is hemodialysis spondyloarthropathy. So this is a dialysis-related amyloidosis, specifically deposition of the beta-2 macroglobulin. Diacetylates apparently in the past couple decades have come a long way, and we're able to get rid of some of these byproducts that were previously left inside patients. But in this case, one manifestation of amyloidosis in the spine would be a destructive arthropathy. And it's discocentric, just like spondylodiscitis, and it's seen in those long-term dialysis patients. Differentiating the two, you can do a biopsy and send for culture, and if it's sterile, I guess it argues for non-infection or a non-infective process. But as we know, those cultures are frequently negative. So an imaging actually helps us help the treating team here. With the scitus osteomyelitis, there tends to be a lot of bone marrow edema, as you guys are aware, including within the surrounding soft tissues. With dialysis spondyloarthropathy, again, you have discocentric bone destruction, but there's not a lot of bone marrow edema. You can see these two levels here. This would be 6 and 7 are barely edematous, which is quite remarkable for how much bone destruction is present. Now, the patient is developing an unstable cervical spine and has some prevertebral edema here, but these findings certainly were in keeping with dialysis spondyloarthropathy. And a biopsy was performed, which showed some amyloid deposition and no evidence of infection. Another differential for a destructive spondyloarthropathy is neuropathic arthritis, the so-called Charcot joint. History is paramount there. So you need to have some sort of history of neuropathy or surgery in the spine to have this diagnosis. This patient had a neuromuscular disorder. Oops. You can tell they have no abdominal musculature, no paraspinal musculature, like no psoas or anything to speak of. So the lack of inflammatory signs in the soft tissue around this area, and including the vacuum phenomenon, shows us this fluid's not under pressure, and this is almost certainly neuropathic arthritis of the spine. So there's a companion case. This is a 53-year-old man who was who was low back pain and left sciatica, also long-term end-stage renal disease. And on this sagittal T2 image on the left, you might be tempted to call the study normal, no disc herniation. But if you look at the T1 weighted sagittal image, you can see there's material deposited in that supraspinous ligament, but also in the interspinous ligaments and ligamentum flavum. Looking at other images in his jacket, you can see both of his hips are markedly distended with material or tissue that is low attenuation or low signal intensity on this T1 image on the left. And then the T2 image on the right, it's also this low signal intensity material. So a differential diagnosis for a low signal intensity synovial process is going to be something that bleeds. So that would be hemophiliac arthropathy can stain the synovium. Also, a tenosynovial giant cell tumor, the entity formerly known as PVNS, bleeds and can cause a low attenuation or a low signal intensity synovial process. But amyloid is the third thing to consider with a low signal intensity synovial process, and that's what this patient had. He also had other findings of amyloid arthropathy in both of those hips, these indolent appearing erosions with overhanging edges and sclerotic margins. So why did he have his low back pain and left sciatica? Well, he also had a hamstring tear on the left, and that created a fluid collection, which pressed his sciatic nerve right up against his distended hip joint. So we got to his answer in a roundabout way, reading his lumbar spine MRI. This is a more common form of amyloidosis in the spine, less often that destructive process, but that sort of deposition process we see with low signal intensity material. But those two things can coexist. All right, switching gears to another type of topic here. There's a 21-year-old man who has low back pain. And we'll start off with an eye test. Where is the finding in this patient? And I'll give you a hint. I'm not showing mild levoscoliosis. You got to vote for that left SI joint. We also have a vote for the L5 spinous. I'm assuming that means spinous process. And that's absolutely where this finding is. Looks very obvious on the AP image now that I have a circle around it. You know, the lamina and spinous process there are fairly expanded. So any thoughts on what this could be? We got votes for ABC, an osteoblastoma, giant cell tumor, ABC, and osteoblastoma. Those are good ideas. And the next question I would ask is, does this MRI support our thought about ABC, which would have been my favorite differential diagnosis based on the X-rays? So no fluid levels like we see with ABC. Like most pathology, T2 hyperintense, not that bright on T1. Here's the CT. Again, we have some expansile remodeling of the spinous process. In this case, we have endosteal scalloping, right? These kind of like smooth lobulations that kind of erode the endosteum of the spinous process and some calcifications. We have a vote for osteoid osteoma, a vote for osteoblastoma. Osteoblastoma is not a bad idea right now. You know, there's a common posterior element tumor. often it causes, can have a secondary ABC that forms, and often it has a lot of inflammatory changes that accompany it. So we biopsied it. And the reason I'm showing it is this is kind of one of the tumors that occurs in the posterior elements that just doesn't get a lot of mention in the differential diagnosis. We all know about osteoblastoma, ABC, and osteoid osteoma. All those things that were mentioned can commonly occur in the posterior elements. But fibrous dysplasia can actually occur back there with some frequency as well. Maybe not quite as common as ABC, but it's something we forget about. So fibrous dysplasia, it's not actually a neoplasm, but it is a bone tumor. It's an area of abnormal bone maturation, and this leads to deposition of this dysplastic fibrous tissue. And also in these lesions, you can get woven bone, which is immature bone that forms. And it's that woven bone that actually produces that ground glass appearance, not the fibrous material, actually, even though we call that the fibrous matrix. The findings are you get bone expansion, you get endosteal scalloping. That's from all the material being deposited and slowly kind of eroding away at the cortex. And these things sit around for a while. You know, they never go away. They kind of fester over a while, so they can develop dystrophic calcifications and cystic change. This case had calcifications, not the cystic change or the kind of fibrous ground glassy matrix that we sometimes see with this lesion. But it does appear to resemble fibrous dysplasia that we see in other bones, a sort of expanded bone with endosteal scalloping and chronic remodeling. All right, now we'll actually go on to the next case. We're going into the real world now, no history, just images. I can make up an age for this patient. We'll say it's a 50-year-old man. He has some right-sided symptoms. I figured you guys would be all over this one. I'm hearing the right answer here. Synovial cyst, facet cyst. That's absolutely it. So this is a big one. This is one coming from that right L5S1 facet. And it's not really the cyst really that matters, is what it's pressing on that can cause symptoms. We see these all the time posteriorly. They're outside the spinal canal, but the ones that are in the spinal canal are the ones that cause symptoms. And that's because the cyst is pressing this L5, or I'm sorry, this S1 nerve root on the right, the traversing nerve root. It's kind of completely flattened and pushed against the vertebral body and disc here. Compare that to the contralateral lateral recess, which shows a normal sized nerve sleeve with that traversing S1 nerve root. So yes, this is the spinal synovial cyst, also called a facet cyst, or ganglion cyst in the spine. These are most common. They're almost all of them are seen in the lumbar spine. For whatever reason, most occur at L4, L5. They can be symptomatic, asymptomatic, especially when small, but when they're large and pressing on nerves, they frequently cause radiculopathy. These can be excised, or they can be percutaneously ruptured, which is something the interventional radiology, or at our institution, musculoskeletal radiology, performs. So how do you rupture the cyst? Well, you blow it up from the inside. So we use hydrostatic pressure. A couple different ways to get into these cysts. In this case, the L5S1 interlaminar space, was quite wide open. And the facet joint had a lot of osteophytes, so the facet joint was hard to get into. So I elected to directly puncture the cyst with a spinal needle. So you guys can all see the spinal needle. That little bit of white material at the spinal needle tip, that's some injected contrast. So after I feel that I'm starting to fill the cyst, and I've kind of mostly filled it from what I see and the size on the MRI. Of course, after I tried to aspirate it, generally aspiration's not too successful. These things are rather small, and the material is often gelatinous. And we don't like to put 18 gauge needles into the spine. But I filled the cyst with the contrast, and then I have a needle, a separate syringe that I have my epidural steroid cocktail in. That's going to be steroid and an anesthetic, short-acting anesthetic, lidocaine. So at this point, if the patient has a really bad radiculopathy, we will give them sedation. This patient was one of those. But if the radiculopathy isn't like really, really severe, This is where we give the patient a nail to bite on and say, okay, this is going to hurt, but just for a second. And we very forcibly inject that epidural steroid cocktail into the cyst until we feel a pressure release. In this case, we felt it. And then now the contrast is filling the epidural space in the spinal canal. Here it is in the surrounding the exiting L5 nerve root. You can't see the L5S1 foramen at this level. It's a little bit of out of plane. But yeah, we can have successful cyst rupture. So I see a question in the chat. Would you recommend doing a transforaminal epidural steroid injection prior to the cyst rupture? And I'm assuming that question is directed at, is this going to make the procedure less painful? If it is, it's an interesting idea. We want to get some of that cocktail in the cyst. And when it ruptures, we essentially do perform a transforaminal epidural steroid injection. It does hurt, but it just hurts for a second. So that isn't something we've tried to do, but it's an interesting idea. The other way to get into the cyst, I'll show you in a second. I'll just first show you the cyst. This is a left-sided L3, L4 facet cyst. Is to access it via the facet joint. These things come from the facet joint, so you should be able to fill the cyst via the facet joint. So on CT, we're able to find an area where we can get between those osteophytes. And here I've wedged my spinal needle between those osteophytes and into the facet joint space. And then I inject contrast until I fill the cyst. The cyst was located at a level a little bit above where I access the facet joint. So that's why you don't see the spinal needle in this image, but you see the facet joint filling with contrast. And you actually see the small little cyst filling with contrast too. So at that point, we do the same thing. We give the patient a nail to bite on and say, this is going to hurt for just a second while the cyst ruptures. We forcefully inject, and then we have basically given the patient an epidural via presumably a rent and a rupture in the facet synovial cyst. You can see here, this is all the epidural fat, and then the epidural fat going in through the lateral recess area and into the foramina. Some of it came out the back too, and that's totally fine. All right, so this is where I haven't done this talk before, but this is where I check my time and see if we have time for one more rep, and we do. So this is a patient, this is a 20-year-old man who had severe back pain. It started a few hours after doing some deadlifting, which is a form of weightlifting. And now for the past 2 days, his pain has just become very severe and unrelenting. So in the sagittal T2 image, just showing you he has not herniated a disc. And his finding is present on these two transaxial T2 images. Compartment syndrome, okay. Okay, someone's saying paraspinal muscle hemorrhage. Any other theories? DOMS. For those of you not familiar, that's delayed onset muscle soreness. We have contrast enhanced images too, as process enhances. Yeah, I really like this DOMS theory. That's very close. So I'll give you another hint. He has a very, very elevated creatine kinase. And he has brown urine. He has myoglobulinuria. Yeah, so this is rhabdo, which is a rapid breakdown of damaged skeletal muscle. in other parts of the world, we probably see this more with crush injuries and immobilization. You can also see it with a medication and electrocution, but we also can see it from overuse, especially in patients who are dehydrated. It's treated really supportively. There's nothing you can do to help the injury per se, but except to hydrate the patient so they don't develop renal failure and correct electrolyte abnormalities so they don't develop an arrhythmia. So on imaging, the imaging findings here are necessarily specific. You couldn't tell the difference between DOMS, which is delayed onset muscle soreness, and rhabdo. In this case, both will produce this kind of hazy, kind of edema-like pattern. Not really a feathery muscle edema pattern that we sometimes see with muscle strain, and it's a more of a diffuse pattern of muscle injury, one that we won't often see with the strain. Here, with muscle edema patterns and muscle signal abnormalities, the history and clinical context is really key. If this guy was just sore after weightlifting, this would certainly be DOMS. If he was someone who had fevers and recent colitis and a white count, you'd think about some sort of inflammatory or infectious myositis. And certainly if he has weakness and elevated rheumatoid markers, yeah, you'd think about the inflammatory myositis. One thing that can complicate rhabdomyolysis is myonecrosis. Thankfully, this patient didn't have that. That would just be areas of muscles that don't enhance. So someone did mention paraspinal compartment syndrome, and that's very interesting because neurosurgery was consulted. This patient was admitted for paraspinal compartment syndrome. His pain was really bad. I'd never heard of that. I thought that was kind of odd when I looked at it in the chart, and I did a Google and PubMed search, and this is a thing. This has been reported, particularly with weightlifters, skiers, and surfboarders. So this is basically a vicious cycle that happens when you get elevated pressures in the muscle compartment from like a bad injury or rhabdo. You increase the pressure in the compartment, that decreases blood flow. It causes more injury to the muscle, which increases pressure, and then so on until you can get actually myonecrosis. And this is very painful, as is rhabdo. It's most often seen in the extremities, but as we were just mentioned, we can see it in the paraspinal muscles. This is in weightlifters and downhill skiers. This is not an imaging diagnosis. They make the diagnosis with manometry and the clinical setting. But we can see complications of paraspinal compartment syndrome, and that would be any areas of myonecrosis, which were not present in our case. So those are all the cases I have for you. We've just posted a webinar evaluation to the chat, so please click on the link to provide feedback. You'll also get that same link for feedback in an email if you don't have time to fill out the evaluation now. I just wanted to say thank you for everyone for coming and listening to these interesting cases, and thank you for the SSR for inviting me to speak to you guys. This is our last webinar for the season, so we are taking a summer break, but the webinar will return in the fall, probably in September or October. We don't have a date yet, but please see your email, and then we'll announce a return date. I actually have time to answer questions too, which I'm starting to see in the chat. First case again, what's the difference between DOMS and rhabdo on imaging? DOMS and rhabdo on imaging are going to be the same. You're going to see that hazy muscle edema, or sometimes with DOMS, feathery muscle edema. The difference is this isn't like I'm sore after doing weightlifting for the first time in 2 years. This is, oh my God, this pain is so bad, it's keeping me up at night, and I feel the urge to go to the emergency room. The difference, you'll diagnose the difference on those with laboratory analysis. You won't have elevated serum creatine kinase with DOMS, but you will with rhabdo. Someone wants to see the first case again. I'm happy to go back. Well, I'm waiting for the other questions in the first case. I see another question. What is the actual significance of an arachnoid web? Sometimes this is confusing. I think an arachnoid web, it will be significant if it's causing significant neurologic symptoms, myelopathy. Sometimes we see these mild webs, as we do here, as we do in this case, that may not be causing the patient's symptoms, but if they're severe enough to cause symptoms, they may treat. Anecdotally, I just know from my limited experience that those herniations tend to cause more severe, are often treated. But in this case, this presumed arachnoid web or cyst, was not treated. Another good question, aggressive hemangioma, need to recommend biopsy only if you're brave. As a musculoskeletal radiologist, we do biopsy a lot of bloody lesions, particularly renal cell carcinoma metastasis. And when that occurs in the spine, we get very nervous, especially when you see that blood jet out of the needle hub. When we do those cases that we know might bleed a lot, we're very selective in which patients we will do. If there's a good solid cortex around the spinal canal, that's very reassuring for us. But if there's not that good shell of bone around the spinal canal cortex, we will often defer biopsy. Occasionally, the patient really needs a tissue diagnosis prior to proceeding with treatment, if that's like their only potential metastasis, in which case we can proceed, but it usually involves a phone call to the spine surgeon who's going to be on call that day, giving them a heads up that, hey, we're going to watch this patient for a few hours after surgery, and probably won't hear about it, but there's the chance you might. If I had to biopsy a vertebral body hemangioma like that, I probably would give a heads up to the surgeon. But thankfully, in this case, this is and what I like about the case of let me make sure we go to that case. What I like about it is we can make the diagnosis on imaging. And I saw in the chat one person said, why isn't this lymphoma? It's kind of this transspatial lesion. Well, it really looks like hemangioma, like on every sequence, except it's just behaving very aggressively. It's just still a T1 hyperintense lesion, which you won't have with a malignant process. There's no MET that's going to be T1 hyperintense like this. So the imaging findings here are pathognomonic for aggressive hemangioma, which is why I like this case. It's an opportunity for radiology to add value to the patient's care and avoid a biopsy. But yeah, it would probably bleed a lot if you put a needle in it. Going back to that web case, are web cases congenital or are they acquired? I don't know, actually. It's a good question. Is it bright on T1 because of blood? It's bright on T1 because these hemangiomas are actually they're technically low flow vascular malformations. And so there's a lot of disorganized, like capacious blood channels. And for whatever reason, these malformations contain fat. So it's actually the fat which makes these lesions bright on T1. All right, so if I haven't answered your question, I do have a couple more minutes. You're welcome to ask it again, and it'll appear at the bottom of the chat. All right, thanks again, everyone, for coming. These were very good questions, and enjoy the rest of your summer. Have a good one.